Hi guys, we're going to talk about chapter 15, anxiety and obsessive-compulsive related disorders. So when we think about anxiety, I think we all have experienced anxiety at one time or another. It is that reaction to fear, the apprehension, the uneasiness from real or perceived threat. Anxiety is also necessary for everyday life. This is called healthy anxiety, and it can really motivate people to make and survive change. It prompts constructive behaviors. For instance, you're studying for your exam, you're arriving on time for a job interview, or you're preparing for a presentation. All anxious times, but it's healthy anxious because you're using constructive behaviors. So let's take a look at the different levels of anxiety. So there are 4 levels of anxiety according to Peplau's theory: mild, moderate, severe, and panic. On this slide, we're going to talk about mild. Mild anxiety is very normal. It occurs every day. It makes us really more aware of our surroundings and can give us better focus. So what do you think about the physical symptoms of mild anxiety? We might see slight discomfort. They may be a little restless, may have some irritability. What do you think a person with mild anxiety might be doing? You may see nail biting, maybe their foot or their finger are tapping, or they may become very fidgety. As we stair-step up to moderate anxiety, our senses become somewhat hindered, so seeing, hearing, or grasping information may be lessened. Maybe we have some selective inattention. Our thinking clearly may be hampered, but problem solving and learning can still take place, but it may not be at that optimal level. So when we think about a patient with those physical symptoms, what will those include? You may notice an increase in heart rate, respiratory rate. They may start sweating or complaining of GI discomfort. And these patients may be pacing very nervously. They may be tapping their hands and their feet, may become more banging in nature. So just remember that mild or moderate anxiety levels can be constructive and signal that something in one's life may need attention or is dangerous. As we continue to go up the stair step here, severe anxiety. This is when a patient or a person is only focused on one particular detail or many scattered details. Their thought process is not smooth at all, and they're really unable to learn or problem solve at this level. So some of the characteristics of those in severe anxiety may include that real just feeling of dread. They can be very confused or dazed. They just have a pure sense of doom. Behaviors become aimed at reducing or relieving those anxieties. So when I say that, what do you think these people are trying to do to lessen or reduce that anxiety? This is when you might see that person continually sweating. They may feel short of breath. They may be complaining of chest pain. They may be yelling or threatening, and that's their attempt to alleviate that fear or that impending doom. So the last level of anxiety is panic. It is the most extreme. We may have seen someone in panic. They really don't recognize what is going on. They may be running around. They may be shouting or screaming, which eventually will lead to exhaustion. Some of the characteristics that you may see with this person is just really that inability to speak, or their speak is just unintelligible. They may feel numb, complaining of chest pain or shortness of breath. These people are truly, truly terrified, and they just want to escape the fear or the danger that they are experiencing. So our first question here is Anita. She's 34. She's shopping with her 5-year-old daughter in a large, busy urban mall when she suddenly realizes the child is missing. Which level of anxiety would likely result? A, mild, B, moderate, C, severe, or D, panic. I think most of us would choose somewhere between C and D as being appropriate. The book states that this woman is in a panic state of mind. The behaviors that may be manifested could be that she's pacing, she's running around, she's shouting, she's screaming for her child. She may be hallucinating or having some false sense of perceptions, like she's seeing people or objects that may not be there. I think the biggest thing to take away from this scenario is just differentiating between severe and panic. Your book has a great chart on page 272 that really distinguishes those differences. Next question. Which behaviors might Anita be exhibiting that would indicate a panic level of anxiety? And I've kind of already said these with that last question. A, seeing and grasping information effectively and quick to make problem solving more effective. B, voice tremors, perspiration, and headache. C, dazed, confused with automatic behaviors aimed at reducing anxiety. Or D, running, shouting, and screaming. Once you look at that chart in your book, you'll see that the answer is D. It's that panic. That's that running around, shouting, and screaming. When you are looking at this chart, remember not just knowing the difference between the anxiety levels is important, but take that next step. How do we as the nurse respond to those anxiety levels? So interestingly enough, when our minds and bodies experience stress, we automatically use defense mechanisms. Coping styles kick in automatically to protect us from anxiety and really maintain that self-image. They can block feelings, conflicts, and memories. Defense mechanisms can be used in very healthy ways, or they can be used in unhealthy ways. Page 274 has a great list of the adaptive and maladaptive uses of defense mechanisms. You may be asked to explain the mechanism that someone is using, and is it healthy or unhealthy, adaptive or maladaptive? So we're going to start into our case study here. Anita finds her little girl, Hillary, close by looking at kittens in a pet supply store window and is obviously relieved. I feel sick to my core, she says. I thought for sure my panic attacks were coming back for good. Anita has, in the past, frequently experienced sudden feelings of impending doom in which I feel like I'm losing my mind or having a heart attack. They started when I was a teenager. All right, we'll keep getting more information as we go through this chapter. So these next few slides are just going to give us a clinical picture, different anxiety type disorders that we may see in the clinical setting. So the first one we'll talk about is separation anxiety disorder. This happens mostly in kids, but can be seen in adults. For kids, this is a normal part of development that may begin around 8 months of age and decline by 18 months. If these people exhibit develop inappropriate levels of separation anxiety, it may affect their relationships. Adults may have a lot of difficulty with romantic relationships. They are likely to be unmarried, and they tend to worry and be very shy and uncertain. When we think about panic disorders, many times we see this as a person arriving in the emergency department, complaining of chest pain, but no other complaints, no other medical cause that would be considered, so we go to panic attack. They may have all the signs of an MI, standing on the chest, impending doom. We need to look at the why. Why is this happening? These attacks can come out of the blue, all of a sudden, but not necessarily in response to stress. They are extremely intense. It can last for a few minutes, and then it can subside. Alcohol and substance abuse can be pretty common with this disorder, especially in adolescence, so just make sure you keep that in mind. Agoraphobia is that fear of those big open spaces. They also, if they're going to feel like they're going to be the center of attention, they will avoid that situation. There are other specific phobias that are listed on page 275 and box 15.3 if you want to take a look at those. Social anxiety and generalized anxiety are very common disorders that we see with our patients. Social anxiety is just as it sounds. They don't want to be out in public with everybody. They may feel like everybody is looking at them negatively. They have a big fear that they're going to do something silly, or people are going to think that they are being silly or acting silly in a public situation. They may think that they look or they sound really awkward. In children, this disorder could be called selective mutism. They don't talk. They hide behind their parents. When they go to school, they may not say one single word during the entire school day. Generalized anxiety disorder is a little bit different. These people with this disorder tend to focus on a worry. They think about worrying all the time. It is really out of proportion of what's going on in their life. They can't sleep. They may have GI symptoms, and many times the worry is about themselves. Are they doing good enough? Family members of these patients really have to continually reassure this patient or this person that they're doing okay, and that they are okay. So this slide just gives you a little bit of an idea of what you could see with generalized anxiety disorder. And then the last one we're going to talk about are just other anxiety disorders. So your book talks about substance-induced anxiety and anxiety due to medical conditions. Substance-induced anxiety that occurs when you use substances. That could be alcohol, illicit drugs, or hallucinogens. And then the anxiety due to medical conditions. This one can be very common with your thyroid disorders because their metabolism is in overdrive. With hyperthyroidism, it tends to cause anxiety, which may look like an anxiety disorder. So continuing with our case study, Anita recalls the height of her struggles with panic disorder. My attacks would come out of the blue, usually when I had already been super depressed for a while. They were so bad that I started being more afraid of the panic attack itself. And sometimes I just stay home from stuff I usually really liked, like the high school football games and even slumber or birthday parties, because I was afraid of having an attack in front of everybody. All right, we're going to move into obsessive-compulsive disorder. This starts in your book on page 279. Obsession is the thought that the patient is having, and the compulsion is the behavior that they are doing. Behaviors are usually very ritualistic. Many times they can exist independently. but most often they exist together with obsession and compulsion and not just one or the other. When you watch this short video, think about what is the obsession and what is the compulsive behavior. So all of these listed here are obsessive-compulsive disorders. They are also all anxiety-driven. So they think that anxiety is the root to all of these disorders. OCD, these are people that have doubts that they've locked the door, that they've turned off the oven, so they will check and they will check and they will check over and over again. Others may have to flip the light switch multiple times. Maybe every time they walk into the room, the light switch has to flip 7 or 8 times. If they don't do this, then they may fear that something bad will happen. So many of these cases that you may see begin in childhood as early as the age of 3. Body dysmorphic disorder. When I hear this, I think of Michael Jackson, not ever really happy with his appearance and always wanting to change it. Most of these people are usually very normal in appearance, but they don't see themselves as normal. So when you start seeing that obsession and then that compulsion of following through with those changes, that's when you start seeing that obsessive compulsive disorder. Changes with these could be skin, it could be hair, their nose, or even their weight. Hoarding disorder is that overaccumulation of just belongings, and they really have no value, and it really interferes with their life. If you guys have ever watched the TV show Hoarders, it's a pretty good showing of that. Hair pulling and skin picking disorders, because of stress or high anxiety, this can start really early, and that pain of hair pulling can help relieve that anxiety. And they may not even be aware that they have this disorder until they have huge chunks of hair missing. And then your other compulsive disorders can be substance-induced OCD or medical condition OCD. So patient complains of frustration with his impulse of to use tissues to touch or grab anything and everything around me. I just feel clean and safe doing it that way. But sometimes if I don't have a tissue, I can barely stand to open a door. This patient appears to have which anxiety problem? A, panic disorder, G, generalized anxiety disorder, C, post-traumatic stress, or D, obsessive compulsive. So it is D, the answer is D, obsessive compulsive. The obsession is that need to use the tissue to touch or grab anything, and that compulsion is having to use that tissue and is really unable to function with everyday activities without them. So you can go back and look at why this happens in people, who it most commonly happens in. Comorbidities, we do see a lot more psychiatric comorbidities with patients with anxiety. It's about 90% of the time with general anxiety and 84% of the time with agoraphobias. So there is a link with comorbidities. We do see lots of neurotransmitters playing a part of causing anxiety and the reduction of anxiety. So many of the medications are based off the idea of how our body naturally works. So GABA is a neurotransmitter that inhibits or puts on the brakes of that excited neurotransmitter. And so many of our medications will focus on GABA and increasing the amounts of GABA. That way we can stop those neurotransmitters from being overly excited. Some psychological theories. With this one, we're going to look at the psychodynamic theories. They suggest that unconscious childhood conflicts are the basis for future symptom development. So Sigmund Freud stated that anxiety results when threatening, repressed ideas or emotions were close to breaking through. So remember him and his iceberg. So that anxiety is that threat. Harry Sullivan believed that anxiety is linked to emotional distress when people's needs go unmet. He also stated that anxiety was contagious to the infant from the mother, and that anxiety felt early in life set the stage for anxiety responses in the future. Behavioral theories suggest that anxiety is a learned response to an environmental stimuli, and cognitive theories were based off an individual's thoughts and perceptions. Cultural considerations may vary on symptoms and how that the individual's culture relates. So application of the nursing process. Remember, the nursing process is the means to helping you think as a nurse. So the biggest thing to look at here is assessment. What are we really looking at with assessment? We need to look at the generalized assessment of the patient. This needs to be patient-centered care. They are the ones that need to be telling you how they are feeling. They are the expert when it comes to his or her own illness. This may be where you elicit information that has helped in the past. Maybe you're going to identify some expectations for patient participation and assess for any cultural, ethnic, and social backgrounds that may impact the plan of care. Self-assessment, we're going to talk about here in a bit. Nursing diagnosis, planning, all those components. So more components of that assessment include physical and neurological examinations, figuring out their source of their anxiety, primary versus secondary, which is just measuring that symptom severity, that clinical impairment, and those comorbid diagnoses. Determining current level of anxiety and assessing for potential harm to themselves. We also need to do a self-assessment. Many times, whatever behaviors our patients are experiencing can also show within us. So if our patient is anxious and out of control, that can display some frustrations and anxiety on our part. So just being very self-aware. Here are several nursing diagnoses listed here. As you go through the nursing diagnosis, this is where we're going to determine based on what we are most focused on for our patient. So anxiety, ineffective coping, chronic low self-esteem, or self-mutilation. What is going to be our priority that we want to help them fix? When we look at planning, we really want to encourage participation. Some of these anxiety disorders may isolate them, so make sure you're implementing participation. But be very careful when you monitor that patient's level of anxiety. If they are in a panic state of mind, that may not be a great time to encourage that participation. So this is where we will break our anxiety up into two groups. Our two groups will include mild to moderate and severe to panic. And we look at how we can therapeutically intervene with these patients. From mild to moderate, many times these patients are still able to solve problems. But as they get more into the moderate level of anxiety, the level of concentration begins to decrease. As the level of anxiety increases, nurses tend to want to change the conversation, which ultimately could increase the patient's anxiety. The nurse has to stay patient-centered and focus on the needs of the patient, providing a calm presence, recognizing their distress, and really being willing to listen. Many times that is very helpful for what we can do for our patients with mild to moderate anxiety. Page 285, table 15.9, gives some great examples and why we intervene for mild and moderate levels of anxiety. Now, severe and panic levels of anxiety, we have different types of interventions for these patients. We have to meet their physical needs and prevent exhaustion. Usually a quiet environment with minimal stimulation and medication may now play a role in this treatment regimen. Excuse me. Restraints are not warranted typically at this time. Usually if you use a very firm, short, and simple statement, that is useful for our patients to feel safe from their own impulses. Page 286, table 15.10, gives examples and rationales for severe to panic levels of anxiety. Other interventions may include counseling, teamwork, and promotion of that self-care. So Anita recalls the help she experienced when she was treated in adolescence for panic disorder. I remember my dad anxiously driving me to the emergency room while my mom sat in the back seat and held me, just trying to keep me calm. My dad gripped the wheel like he was afraid we'd go off the road. When we got to the hospital, I remember a nurse came right out to grab to the car and opened my door. She didn't grab me or anything. She just said, "Hi, Anita. My name is Betsy, and I understand from your mom's phone call that you are having a panic attack. I'm here to help you get through it." When she held out her hand, I've always felt like Betsy saved me that night. Which was probably the most helpful thing Betsy did for Anita that night? A, left her by herself in a quiet, dark space to calm. B, stayed with her and kept up a steady stream of talk about anything at all to distract and soothe her. C, introduced her to a bright, pleasant game with other patients her age to create a much-needed distraction from worry. Or D, stayed with her in a quiet spot and listened. So the answer here is D. Always stay with the patient during panic level anxiety. Speak in a low, calm voice, using short, clear sentences. Minimize environmental stimuli. It's also important to listen for themes in communication. In severe to panic levels of anxiety, verbal communication themes may be only indication of the patient's thoughts or feelings. Suppose you are a nurse or social worker on duty when a child goes missing, but unlike Anita's child, it's not immediately found. The police arrive on the scene, the parent is questioned, and as the search intensifies, you are asked to remain with and take care of the anxious parent. What would be some appropriate interventions for helping a parent experiencing panic level anxiety? So we've talked about some of these. We want to really maintain that calm manner. We want to remain with that patient or that parent. If we leave that parent, they may feel abandoned. Minimize that environmental stimuli if at all possible. Move to a quieter setting if possible and stay with the parent. Use clear, simple statements and maybe you have to repeat those. Use a low-pitched voice and speak slowly. And really recognize the anxious person's distress. If they start commenting on things that they are seeing or they are hearing that aren't really happening, try to find a way to bring them back into reality and really be willing to listen to this parent. So the ATI lesson that you were assigned is really good. But I just want to reiterate some of what they said. SSRIs are considered the first line of defense in most anxiety and OCD related disorders. Benzodiazepines are most commonly used as an anti-anxiety because of their quick onset of action. Buspar is a non-benzo, and it typically takes 3 to 4 weeks to notice the effects. This is not a short-term medication, and it is used for long-term. I think your lesson stated it was short-term, and it is not. It is a long-term used medication. These are some advanced practice interventions. So remember, we're not training you to be advanced practice nurses, but some of these things listed here, especially in the behavioral therapy, can be helpful when dealing with someone that is having an acute exacerbation of anxiety. Relaxation training or deep breathing, modeling. Remember, we are going to show that appropriate behavior. Systematic desensitization is for someone that has a fear of an object. We may go through a series of steps, moving from least frightening to most frightening. And as you move through those steps, the anxiety should be lessened. Flooding is the complete opposite of that systematic desensitization. If a patient is fearful of mice, you put them in a room full of mice. I can't imagine that being very useful, but I'm sure there are some out there that would benefit from this therapy. And then thought stopping is one when they're having obsessive thoughts. You can put a rubber band around their wrist and they can snap it every time they have that thought. When you are evaluating how your patient is doing, you can ask the following questions. Is the patient experiencing a reduced level of anxiety? Does the patient recognize symptoms of anxiety related? Does the patient continue to display signs and symptoms such as obsession, compulsion, phobias, worrying, or other symptoms of anxiety disorders? If they're still present, are they more or less frequent, more or less intense? Is the patient able to use newly learned behaviors to manage anxiety? So those are those coping skills. Does the patient adequately perform self-care activities? Can the patient maintain satisfying interpersonal relations? Is the patient able to assume their usual roles? So our last question here, what is your usual level of anxiety on the day of a nursing exam? A, mild, B, moderate, C, severe, D, panic. So all of you are going to have a different answer for this question. Take a look at what your level is. If it's impeding on your success of the exam, then we need to chat and come up with some strategies to help lessen that anxiety. If you have questions or concerns regarding this chapter, we can talk about it in class, or you can shoot me an email. Thanks, guys.